appointment, and the other appointment that they'll be offered is a 12-week dating scan, and that's their first scan in the NHS. They're not routinely offered any scan prior to this. It's 12 weeks. And if all being well, so then the next appointment for a first-time mum is 16 weeks, and that will routinely be with a midwife. If anything has been identified where the mum might be slightly higher risk, which I'll come on to in a minute, what would make them high risk, they would be offered to see an obstetrician at 16 weeks instead of midwife. We are asking at Kingston that at 16 weeks, all mums come alone to that appointment, so we can ask them about domestic violence. Routine national domestic violence screening is to be asked at 16 weeks. And then after the 16-week check, they'll be offered a 20-week anomaly scan, and that's where they can find out the sex, the gender of the baby if they wish. And at Kingston, we now measure something at 20 weeks called Doppler flow resistance. Now, this 20-week scan is often a really crucial point where mums will become very anxious, and you'll probably find you get a lot more perinatal referrals after 20 weeks from mums having either bad news at scans, or having this like increased Doppler flow measurement, which means that they're slightly higher risk of developing preeclampsia, and they are offered extra scans in the pregnancy, and then they often go on to a consultant-led pathway. So it's quite a scary time for mums, that scan, because they thought they were just going along to discover the gender, check things are okay, but then they end up having complications coming from it. And obviously at that scan, the whole baby is looked at, and if there are abnormalities, they're often told at that scan as well.
Lucie,
yeah.
Are you changing your slides? Because you're still on the second one.
Yeah, I'm just talking through the pathway.
Are your slides, are you talking from the slides? I just wondered if you were talking from slide 2 still.
Slide 3, antenatal journey.
It says you're on 2.
What does the slide say?
It's just got antenatal journey, labour induction, and an ELCS.
Oh no, I've changed my slide.
Yeah, it's not changing on here.
Oh.
Do you want to unshare again, Lucie? It might be.
Oh, I tell you it. Now? No, still?
Now
it doesn't. I found out the other day that it doesn't work on slideshow. It doesn't work to do from slideshow from the beginning when you're on Teams for some reason.
What about now? What about now?
Yeah, that's the third slide.
That's
now,
That's better.
journey.
Okay, I'll just leave it like that. I think it's because I tried to put you on the other screen as well or something. So, sorry, I was saying, yeah, so at the anomaly scan, we often find clients very anxious at the scan. Then they're offered 4 weeks after that. We ask them to see their GP for first-time mothers only. If the GP doesn't want to see them for whatever reason and they don't find it very successful seeing their GP, and a lot of our clients have troubled relationships with their GP practice or their family doctor, we will see them in the midwife clinic. And then they're offered routine 28 weeks, 32 weeks, 34 weeks, 36, 38, 40 weeks and 41. So first-time mothers are expected to attend a total of 10 appointments, and second-time or more mothers expected to attend 7 appointments. So if a mum's had more than one child, we call them a multip. If it's her first baby, primip, which I'm sure you're all very familiar with now. So at the antenatal check, whether they're seeing a midwife, an obstetrician or a GP, the routine antenatal care should always be the same, and this is nationally. So we always dip their urine test that they provide in the hospital. We ask them to provide the urine test in the hospital because working on our team with mothers that may have a history of substance misuse, we even have mums that sometimes bring in their partner's urine, or they try and do something else with the urine bottle, put water in it. So we give them a urine bottle, and a tip, I put a scribble on the bottle before I give it to them, and then I know if they've swapped it in the toilet or not. We have caught out a couple of mums doing that. But just for your average mum where there's no substance misuse, we would just routinely test any glucose, any protein, urine infection, ketones, and if we felt that it needed to have further testing, then we send it to the lab. If a mum's got a history of substance misuse in the last 12 months of booking with us, then we would request that we send that off to our lab for further testing. We do not test in the hospital for alcohol. There is no way of testing via the urine for alcohol, and we don't do any special blood tests for alcohol misuse. Every check would include a blood pressure check for the mum, and from 16 weeks we'd start listening to the fetal heart rate. We don't listen before 16 weeks because it is too early to find the fetal heart rate, but from 16 weeks, every check they will have a listen with the sonic aid, handheld Doppler, for 60 seconds. And we'll ask mum at every check, how is your baby moving? And we would expect from 28 weeks, the mother has a pattern of movements. If mum was to say to you or a clinician that the baby has not been moving, we would really advise that they attend our day assessment unit or our maternity triage. Even if they're a bit unsure and they think it's been moving, but they're still not sure, we'd still advise they come and get a check. And from 24 weeks, we always measure the mother's the fundal height, and we'd plot this on a graph in the handheld notes and see how the stomach is growing, correlating with how many weeks they are. We do expect mothers' fundal height to be plus or minus 3 centimetres for how many weeks they are, and then in the later stage of pregnancy, plus or minus 2 centimetres. If that was measuring out of range, then we would request a growth scan for these mums. But if everything measures completely normal, they're only routinely having 2 scans in the pregnancy, 12 weeks and 20 weeks. If they have risk factors identified, then they will be put on the growth scanning pathway, which is additional scans at 28 weeks and at 32 weeks. And high risk in terms of risk factors that your clients mainly, low BMI, high BMI, if they're on any certain medications, then we'd put them in for extra growth scans. We also obviously ask about their emotional well-being at every contact, and also try and do domestic violence screening when the client's alone where possible. At booking, we do ask if their height and weight can be checked, and we wouldn't need to do that again unless their BMI was over 35. And then 2 vaccinations are currently offered in pregnancy as routine, the whooping cough vaccine and the flu vaccine. If it's in season, then any time from a positive pregnancy test, the flu vaccine can be given. And whooping cough vaccine, the ideal time for this is 20 to 32 weeks. We do talk to these mothers about why we'd recommend them having the vaccine and what the risks are and how it protects the baby as well. So the routine blood tests that mothers expect to have, HIV, syphilis, Hep B, full blood count, blood group, antibody screen, and a hemoglobinopathy screen. And at 12 weeks, they are offered the screening tests, which is a simple blood test, and it would show us the risk factors for Down syndrome, Patel's, and Edwards syndrome. If that was to come back high, then the screening team would be further in contact with these mothers and suggest additional testing. But at first, it is just a non-invasive blood test. And then at 28 weeks, the next set of routine bloods is another full blood count and a group and antibody screen. Often at 28 weeks, we do find that mother's iron level drops, and it's not abnormal for mothers to need to start iron tablets or even have an iron transfusion or blood transfusion. The baby's taking quite a lot from the mothers at 28 weeks, and that's when mothers often will present tired, lethargic, low in mood, and just a bit wiped out, and we often do their iron test and we find that they need to start supplements. So if everything is well in the pregnancy, they're the 3 sets of bloods I have, and also the 2 sets of scans I have.
Lucy, there's some questions on the side.
Oh, sorry.
That's all right. Maria's asking if there's any protocol for monitoring fetal alcohol syndrome.
So there isn't there's a guideline which suggests that they are seen by fetal medicine unit for a fetal medicine scan. So if a mum identifies as drinking at booking, then we would speak to fetal medicine consultant. But we don't have there's not really another protocol at the moment for that.
Okay.
And postnatal, I mean, once the baby's born, we would assess in the neonatal unit, observe the baby. The same as we would do with substance misuse, with drugs.
Yeah.
And
It seems we're doing a little bit more for substance misuse than alcohol, aren't we?
yes, I think because alcohol misuse is hard to identify. It's like,
Yeah.
it's hard, isn't it?
Yeah. I wonder, perhaps this is something we need to think of, because we have a couple of patients at the moment that are quite troublesome in that sense. And I put in the chat, Lucy, if there was any protocol they were using at St. Helier or St. George's. Lina and Lila are here. But Lila just said, I've been told that St. Helier's are using mirroring what Kingston does. And I'm not sure about St. George's. Lina?
Sorry, St. Helier are, so in terms of their monitoring, they are. But
Similar.
otherwise, the for alcohol, yes, similar to exactly what Lucy said, is that they refer them to fetal medicine, and then they review them similarly as they would for substance. But like Lucy says, there's not much you can do.
Yeah.
And at St. George's, it's the same, fetal medicine referrals. Yeah.
Sorry, Lina, you're very faint. We can barely hear you.
At St. George's, they offer the same as Lucy said, with the fetal medicine referrals and the additional scans.
Okay. Do we have a sense how much our ladies drink at the end of the day? Because I know we asked, but I just always wondered. Sorry, I don't want to interrupt you, Lucy. I was just thinking a bit loud.
Yeah.
Sorry.
Well, I don't think they're often very truthful. I think it's really hard to get a measure on what's actually going on, unless you get a police call out or something where the mother is intoxicated.
And these are the couple of cases we had recently, because there was a referral, mass referral, and that's where we got it from, really, that the mum, when they turned up, was intoxicated.
I mean, we would put them on the additional growth scan pathway as well, and FMU, but sometimes when it's late on as well, it's really hard to see the picture of the baby. So it's kind of like once the baby's born, have to then assess as well and see if the baby withdraws or anything.
Mm-hmm. Thank you, Lucy.
Thanks. So standard information that we give to every mum at booking, and often a lot of questions will come from the clients to other professionals. We do give them a lot of information that's very easily accessible in their handheld notes. So at Kingston Hospital, we are still completely by paper. So they have their own handheld booklet, maternity booklet, which is just for their maternity care, and they must bring it to every appointment. They should be carrying it around with them, and we ask them to take it away with them if they go on holiday, etc. So if you ever want to catch up with what a lady's been having appointment-wise with us, or the latest check or something, you can ask if she'd show you her maternity booklet, and each contact is quite clear of how many weeks they were and what was discussed at that appointment. We give every mother an FW8 form at booking, which is an electronic form to give them access to free prescriptions and free dental care because they're pregnant. So every mum will be given that by their midwife, and it's then emailed to them and they can use it straight away. That's no longer sent in the post. And then from 20 weeks, we'd give them a MAP-B1 form if they need it for their work, and that has to be from 20 weeks. Once they've had their 20-week scan, they can collect it from their midwife or the maternity reception at Kingston Hospital if they're really desperate for it. And then inside the maternity notes is something called Your Pregnancy Care Information Pack. And this information pack is just for the clients, and I encourage them to take it out of their notes and start reading through it as the pregnancy progresses. And it's put into really clear sections of like weeks 1 to 13, 13 to 20, and so on. And it even has a really nice what to pack in your hospital bag. And a lot of mothers will ask this very late on, like the day before they're due to come in. We try and show them this list around 36 weeks and start encouraging them to start packing their hospital bag, and it can help them try and create a bit of a bond and getting ready for the baby as well. We have had a lot of clients recently come through and they just haven't got anything prepared for the baby. We have a lot of equipment in our office that kindly our maternity support worker, who's called Sam, gathers from free sources, and we store it in here. And if we have a mum present unbooked or concealed pregnancy, we do have things we can give to them, or if mums are really vulnerable and don't have access to anything. But you think if they've known about the pregnancy for 8-9 months, they really should have enough time to try and get little drips and drabs together for their stay. Just the essentials, such as maternity pads and knickers and spare change of clothes and a spare change of clothes for the baby. We give them advice on parent education groups, which are free at Kingston Hospital and run by our midwives. At the moment, these are online and by MS Teams. And we encourage them to do it around 32, 34 weeks, because if they do it too early, they seem to forget all the information, and that seems to be quite a good time to engage them. And we also give them information on infant feeding, whether they wish to breastfeed or bottle feed. And we have a specialist infant feeding team at Kingston Hospital, should mums wish to have further support. I've had a couple of clients under the perinatal mental health team who have to bottle feed due to their medication, and the infant feeding team have done a one-to-one session with them to talk about bottle feeding. It's made them feel really a lot happier with the choice as well. I think a lot of mums get very down when they feel that they have to bottle feed, or just because mental health medication.
We've just got a couple of questions in the chat.
Oh, sorry, you've got some questions in the chat.
One is, does routine blood tests include thyroid function, LS2s and UTNEs? And that's no. Can everyone hear me?
Can everyone?
The reason why I ask this question, because there's a lot of patients who are already on antipsychotic medication. So knowing if you don't do it, so we can request from GP. If you are doing it, that we don't need to then duplicate situation and expose the women to have further blood tests.
No, we don't do those as routine. And it would be quite difficult to add that as a routine for the normal community midwife bookings, because sometimes we don't know about their mental health history until they're under you. So we can certainly do those tests later on in the pregnancy if it's easier, but for the initial one, no.
Okay. Thank you.
The thyroid function we ought to do if they're on any sort of thyroxine or anything. And then there's another question about, is Strep B screening routine?
Strep B, no, we don't screen for Strep B. I don't think any of the South West London hospitals, I could be wrong, but screen for Strep B. Mums can get a private test at the GP, but if we need to do a vaginal swab for any client, if they're presenting with any signs of infection or thrush down below in the pregnancy, it will pick up if Group B strep is there. The reason why we don't routinely screen for it is because it can come and go, the flora, and if a mum, for example, doesn't have it at 37 weeks, she could have it in labour at 40 weeks and vice versa. So the evidence base for routine testing isn't great.
And Kingston were recently doing a study into Group B strep. So it may become routine in the future, and they were looking at actually producing a vaccine for Group B strep, but that's not actually finalised yet. Right, next question is there any mention of maternal mental health during the parent education groups?
Yes, I had to record a really nice video from maternal mental health, so they do a whole session on it.
And any update about COVID vaccines for pregnant women? So pregnant women can now have COVID vaccines. I don't actually know what antenatal clinic is saying to them though, do you?
No, they are saying, I'm echoing a lot. Sorry, Jo. So they are saying that it is okay, safe to have the vaccine in pregnancy, but we're not issuing them at Kingston Hospital for pregnant mums. I think if they fall into the criteria or from there get invited by the GP, we don't have a supply here that we're giving any pregnant clients that I'm aware of.
There's been some recent guidance sent off. I can share it with the team around, and I think Charlotte, you have it as well. Charlotte.
Yeah.
Clifford. Yeah.
Sent it to me. Yeah.
Yeah. Do you want to share what the key elements of that were in the recent guidance?
Well, I think it just said that because the US have been vaccinating pregnant women, I think they've got sort of stats of about 80 or 90,000 women who've had the Pfizer or Moderna without any kind of increased risk. So I think from my understanding, the guidance is sort of saying, yes, if you fall into the criteria, but ideally, if you can get a Pfizer or Moderna, just because we know that that one's been used in America safely. I think that's basically kind of the summary.
Yeah.
Thanks, Charlotte.
I can send it now. That's what I sent to Charlotte.
Yeah.
Yeah. I only sent it initially to Charlotte and Charlie because they were pregnant. But yeah, I'm sending it to the team. I'll copy you and Joe, Lucy.
Thank you. So the kind of possible common high-risk clinics that many clients might attend could be the diabetic clinic, the fetal medicine clinic. If there's any screening abnormalities picked up or any blood disorders, then they'll see fetal medicine and the screening team. There's a preterm surveillance clinic, so if mothers have had previous preterm deliveries, then they'll be under the preterm clinic, and the consultant obstetrician in that clinic does do like cervical length scans, and we'll keep a check on those clients. There's a hypertension clinic, obviously mental health, which we link with NNU for any medication complications or anything that we see with the neonate, and safeguarding clinic as well. There's a birth options clinic, which any mother that's had a previous cesarean section will be invited to talk about the pros and cons of having a vaginal birth after cesarean section. Birth reflections clinic, perineal trauma, and twins clinic and anaesthetic clinic as well for any mums that might have like complications with having epidural or anything. I think that's the main clinics that we've covered. There is at Kingston Hospital a lead obstetrician for mental health called Miss Woolcock, and she started up the obstetric clinic on a Wednesday next to perinatal and next to mental health and midwifery to try and do a bit of a one-stop shop and attend our pre-birth plannings on a Wednesday. Yeah, it's working okay. She just has quite a lot of other clients in her clinic for other, whether it just be like normal obstetric care they need or other high-risk things. It's just about working out her template a bit better. But she'll see all the mums with any history of severe mental health.
And hopefully we can start evaluating this clinic as well, Lucy. We said that would be one of the next objectives, and we have a trainee that might be interested, one of the obstetric trainees who's just started, the high trainees.
Oh, that'd be great.
Yeah.
So does anyone have any questions on the antenatal journey that we've covered? And I'll just add that at Kingston Hospital, continuity of care teams are being set up, and we've now got 3 successful continuity of care teams, which is based on the client's postcode, and they will be cared for by the same 1 or 2 midwives throughout the antenatal period, labour and postnatal period, which is really great. But we have still got a lot of other clients that obviously fall into just the normal midwifery clinics, which they'll see a different practitioner antenatally, in labour and postnatally. So we're still trying to improve that at Kingston. Does anyone have any questions on the antenatal journey bit?
I just put one in the chat, Lucy, about, I know there's probably, these are the teams you referred to, the continuous care teams. Ruby, Emerald, is this the ones?
Yeah, so there's Ruby team, Emerald team.
What's the difference between them?
So they're just postcode. So Ruby team, okay. Yeah, Ruby team's Roehampton and Wandsworth. So it bridges the gap between the clients that are coming to Kingston from St George's Patch. So they visit them all postnatally. And then Emerald team is a continuity of care team for people that have had previous cesarean section that wish to have vaginal birth.
Okay. Is there any other that we should be aware of?
And then there's one more, which is like the birth centre normality continuity of care team, which I need to remember the name of this one. It's just been set up. but the main one is Ruby Team and Emerald.
Yeah, these are the ones. Okay, and the home birthing
There
team.
are some. Sorry, Maria. There are some other little continuity teams coming up in the community teams themselves. So I know Richmond team have Barnes continuity team, which consists of a couple of midwives in Richmond team, and they have someone on the postnatal labour area who's doing that stuff. And I think every team is doing that slowly but surely, but it's just taking a bit of time to roll it all out because it takes quite a lot of work to get these teams up and running.
And then we obviously have the home birth team as well. Is that what you're going to say, Maria?
Yeah. It's a different team, isn't it?
Yeah, and the lead of the home birth team, Frances Rivers, she's really great, and she's looked after a couple of our really high-risk mental health mums who have wished to have a home birth, and she's given them very good continuity and monitored them postnatally and has been on board with the perinatal plan. So absolutely anyone can have a home birth. And they can refer for home birth at any stage as well. But that is done by postcode, so if they did live out of Kingston area, they would most likely have to look at the local hospital for the home birth.
Right, so it's just for Kingston Borough in that sense.
And Kingston, Richmond.
Okay.
Yeah, it does. It kind of is a bit discretionary as well with Frances about how far they'll be able to travel as well. So, yeah, it's worth them checking with us first.
Thank you.
Okay, so going on to labour induction elective section. So when the mum is in spontaneous labour, she will most likely be cared for by a different midwife that she hasn't met before. But the aim is of the continuity of care team that she is going to see the same person that she has seen antenatally in labour. We obviously ask in the pregnancy, would they be happy for a student? And they, a lot of mums say no, and it's absolutely fine for them to say no. It is their choice, but it would just be one student and usually a female in the room. Once the mum is in established labour, then we will be giving them a single room, which has an ensuite bathroom. But if they're admitted with us for induction or early labour, then they should be made aware that it's most likely going to be an induction bay, which consists of 4 or 2, one other woman. And that's just the way the antenatal ward is at Kingston Hospital. We do try where possible for all of our mums to have, oh goodness, sorry, 1 second, Joe just needs to ask something. Okay, I'm going to finish this slide, and then there's something going on in the car park. So Joe Winterbottom is going to take over the slides, and then it's one of our perinatal clients, Maria. So I'm going to go to the car park because Lynette apparently is struggling. It's always the way. So yeah, we do make them aware that they can be in a bay, and their expectations should be managed, because often mums will come in and they'll start complaining that they didn't realise they're going to be with another person, they're really anxious, they're claustrophobic, and we will, where we can, give them a single room. But since COVID, the single rooms on the antenatal ward have pretty much gone because they're for isolation only. And then if the client is due to come in and have an induction, again, please, clients need to be aware it can take up to 3 days. It does not mean the day they come in for induction, they're going to meet their baby that day. So we really do try and tell them this. And even in pre-birth planning, we do speak to them about this as well. And this will be the same whatever hospital they deliver in. And if they're booked for an elective cesarean, these happen between Mondays and Fridays. They're not carried out on a weekend, but they are all carried out by the consultant obstetrician. And sometimes Miss Walcott will try and do these cesareans for our very vulnerable high-risk clients, which is really kind of her. But again, at Kingston Hospital, a date for cesarean is only given at 36 weeks. We sometimes can get them a date a bit before this, but the reason why is that it can be changed around, the date. So if we give them a date at 28 weeks and then it's changed at 36 weeks, that can throw them mentally as well. So it's sometimes just explaining to them why we give it so late, the date. They can have authorization for the cesarean section a lot earlier to put their mind at rest, but it's just the date. And at Kingston Hospital, our cesarean rate is actually quite high at the moment. I think its elective section rate is about 38%. I think at St George's and St Helier it is lower. So there is some work around looking at how we can reduce the rate as well. And then post-op, once the mum has had the cesarean, again, she does go to a recovery bay area, which has 4 to 6 people in it. She'll be there for about 4 to 6 hours. But once she leaves that post-op care area, if everything's fine, they're very lucky at Kingston Hospital. They most likely will get a single room for free, because the way the low-risk postnatal ward is built, it's all majority of single rooms. It's very different to Gwilym Ward at St George's Hospital, where it is lots of bays. We do have the odd bay there though, so it's just about managing again their expectations. So yeah, I'm going to let Jo carry on with the next slide, which is going on to the postnatal journey, and then I should be back hopefully. So Jo's going to go on to this one.
Good luck.
Right, guys, sorry about that. Right, Lucy wrote these slides, so anyway, okay. So can everyone hear me okay?
Yeah.
Yep, lovely, fab. Okay, so from a postnatal point of view, most women stay in the unit for about 24 to 48 hours. We don't push women to leave. I definitely encourage women to make sure that they're happy with how baby's feeding before they go anywhere. If they did have any complications in labour, so maybe if they had a big blood loss, if baby had passed meconium before delivery, then they do need to stay a bit longer. If baby needed any antibiotics, then they could potentially have to stay for 5 to 7 days. That is quite unusual, to be fair, but just they do sometimes need to just know that that is a potential. Routine elective cesareans can now go home after 24 hours, but again, everything has to have been completely straightforward and normal for that to happen. Yeah, so anyone who's got any history of any mental health problems, then we do offer them to stay for longer, and then they can see us, they can contact us, and the ward will contact us also, and we'll just pop in normally and say hello. We've got a specialist infant feeding team, which are based upstairs on the ward. So any problems with feeding, breastfeeding or bottle feeding, they're around. So they can show people how to sterilise, how to make up bottles, so that they're all happy with that before they go home. One thing that's become much more common in the last few years, I don't know if you've heard much about it, are tongue ties. So this can affect the way babies feed. It can make the latching on very difficult, and we do have our own tongue tie clinic here at Kingston, so we can quite often get the women seen before they go home, and if necessary get the tongue tie cut. The infant feeding team like to leave that a little bit longer now, so that we're not jumping on tongue ties too quickly. So ideally you want to wait about 3 days before that happens. Kingston did start offering the BCG vaccine, because we didn't used to do that because of our area, and now what we do is a sort of a referral system. So we've got a checklist, we go through it. If they need a BCG vaccine, then we refer them for that to happen. So it doesn't routinely happen for all babies now. Once the ladies are ready to be discharged, the community teams will follow them up once they go home, and that depends on their postcode. So we cover quite a broad area around Kingston Hospital. And if they live out of our area, then we'll refer them to any of our other local hospitals. And we've got a system called Stow, so we send all the paperwork via Stow online. And if there's anything particularly sensitive or anything that we feel they need to know more about, then we actually call the hospitals and either speak to their specialist teams or their community teams, just so they've got all that correct information. So the women get seen after they go home the following day. So it doesn't matter what day they go home on, they will always get seen the next day. We always see all women on day 5 because there are some postnatal checks that need to be done on baby at that time. And we can't do them before that day. So that's called a newborn blood spot test, where we test baby for lots of rare conditions. So little blood test that we take from the heel. And then we routinely see women on day 10 and possibly up to day 14. Normally, if everything's okay, they do get discharged from midwife care on day 14 at the latest. We do offer the enhanced care for women who've got any sort of mental health safeguarding issues, and that can go on for up to 28 days. After 28 days, then the health visitors have to take over. We're not allowed as midwives to carry on care after 28 days. So generally, we make a plan with the women as to how often they feel that they need visiting and how often we feel they need visiting. And then we can do a combination of visits and phone calls in that time. It doesn't always have to be a visit. At each of those postnatal visits, we'll do a check of mum and baby. So we do, on the first visit, we do blood pressure check. If they've got no other problems with the blood pressure, then we won't do it again. But we always do check mum's bleeding. We ask lots of questions about feeding and how they're feeling. And then we do some weight tests and the newborn blood spot test on baby as well. And that kind of varies as to how much weight baby's lost and how quickly they're gaining weight again. We always advise women to attend A&E if there's anything urgent. So obviously if they're worried about their baby or themselves. Otherwise, they can always contact the community teams. They have got the community midwife number, and they've also got a 24-hour urgent number that they can call if it's something in the middle of the night that doesn't require an A&E attendance. Once the midwives discharge the ladies, then the health visiting team will take over, and the women also have a routine GP follow-on check at 6 weeks. So that's all women. They have a check where the GP will ask them lots of questions about how they're recovering from their delivery. They also will do a check on the baby as well, where they do sort of a full checkup. And they'll do the first lot of vaccinations at that appointment also. Okay, so that's the postnatal. Anyone got any questions on that slide at all? I can't actually see the chat at the moment, so I don't know if anyone's asked anything.
Yeah, I was just asking if there's any reason why there seems to be more tongue-tie diagnosis, because I've just noticed that over the last sort of year and a half, maybe 2 years, there's more and more babies seem to have tongue-tie. Yeah,
I mean, there was some discussion about the correlation between the use of folic acid and tongue ties. But actually, I was on a feeding study day yesterday, and they're not sure actually if that's correct or not. So, no, I don't really know. But I don't know if it's just because we're a bit more aware of picking it up now, maybe. Yeah, and there's some sort of genetics involved in that as well. It seems like if obviously mum had a tongue tie or feeding issues, then often it kind of follows on.
I just noticed in the clients that we see, I mean, at least once, twice a week, I hear about tongue tie. So I don't know whether, you know, what is that about in terms of our clients, or that is part of the broad, you know, and maybe, I don't know, maybe is there 1 in 10, 1 in 20, I don't know, women have babies with tongue tie.
I don't know the statistics, to be fair, but I mean, certainly when I first came into midwifery, it was something that you didn't hear that much about, and it just seems to have got much more common. But I think now they're trying to kind of rein it back again, because I think a lot of tongue ties are getting diagnosed very quickly, and often they're tongue ties, but they're tongue ties that could actually be dealt with just by doing some feeding support rather than actually cutting the tongue tie. So I think there's just kind of I think everyone was very quick to diagnose tongue ties in the last sort of 3, 4, 5 years. So I think hopefully we might see a little bit less of it moving forwards.
Yeah, because I think especially women, maybe some of the anxious women we see, it gets very much caught up then in the whole feeding issues, you know, and it becomes a huge focus then in terms of the pressures around baby being fed.
Yeah. And I think they hear so much about it now. Their friends mention it, so it's straight off. If they're having any problems feeding, they're right on there. Oh, it must be a tongue tie. It must be a tongue tie. I want it assessed.
Yeah.
So I think women know a lot more about it now than what they did before. But if you have got anyone asking you about tongue ties, then you can refer them back to the community midwife teams or the health visitors. So, like I said, here at Kingston, we do actually have a tongue tie clinic. And it's normally the community midwives that refer the women to those clinics. So just be in touch with us and we can sort that out.
Okay, thank you.
Another thing that people might ask you about when they see you in the postnatal period is our reflections clinic, or if they feel that they want a debrief. We're not allowed to use that word anymore, but so if they want to have a chat about their labour or their experience in the hospital, if they're feeling that is making them more anxious or they're feeling a bit stressed about it, then we have a midwife who does these reflection clinics. So I don't know if you can just see that on the screen, but she's called Sarah Salinger. And like Lucy said, we'll send these all out for you, so you can actually email her yourself if you feel someone needs to actually have a chat about their experience. Okay, so these are some things that women might mention to you if you're seeing them during the antenatal and postnatal periods that really do need some sort of further investigation. So if anyone ever mentions that they don't feel their baby's moving as much, then often that baby's giving us an early warning sign that they're not happy. So that would definitely need a phone call to the day assessment unit or to the triage unit. Those numbers should all be on the front of their white notes. They should also have on the front of their white notes a phone number for their community team, and it should tell you what team they're under also. So there's always someone for them to contact. So either encourage them to call, or if you feel that they're not going to follow up on it, then you could give them a quick call yourself. If anyone mentions any itching on their hands or feet, this could indicate that they're developing something called obstetric cholestasis. This is a disorder of the liver that happens in pregnancy. It goes away once the baby's born, but it can be pretty serious, and it does increase their risk of stillbirth. So definitely something to chase up on. If anyone mentions headaches, blurry vision, visual disturbances, or pains in their lower chest, then this could indicate that they have preeclampsia. Any sort of bleeding in the antenatal period is a concern. Also, bleeding postnatally, if they start passing clots, so anything bigger than a 50p piece, and if they're soaking through more maternity pads than usual, then again they need to speak to the maternity unit. If they seem to have any, so swelling of the hands and feet is really common in pregnancy, but if this happens quite quickly, so if they wake up in the morning and suddenly their hands and face and feet are really swollen, then again that could indicate some preeclampsia, so it does need some investigation. Any swelling of their calves, pain in their calves, or hot red patches could indicate any deep vein thrombosis in their legs. High blood pressure. You're not going to be checking high blood pressure, but we've talked about the symptoms of high blood pressure. Shortness of breath. So that also can indicate pulmonary embolism, so DVTs maybe that might have travelled. Shortness of breath, however, just to be aware, can actually be a sign of low iron levels. So if you do have a woman who's a bit breathless in your clinic, it's not a reason to panic. It's definitely worth an investigation though. Any women, so this would be more of a postnatal thing, so high temperatures could mean, especially if they had cesarean section, could mean some sort of wound infection. Again, if they're passing any offensive smelling blood, again, you might be wanting to think of a maternal sepsis or infection. If they come to clinic and complain that they're leaking fluid, so they often think they might be just passing a bit of urine, they've lost the control. But if it's continually happening, that needs to get checked out because it could be that their waters have broken. Abdominal pain, so any sort of irregular tightenings or contractions could mean that they are in labour. So even if they're 32, 34 weeks, they definitely need to get that checked out. If it's a constant pain that's not going away, then we would be concerned that there could be a placental abruption. So that's definitely an emergency and needs to get investigated. Also, from a postnatal point of view, if they complain about particularly hot, sore breasts and they've noticed red patches, then that could indicate mastitis. So another thing to be contacting the midwives about. Okay, so this slide just tells you a few contact numbers for who to get in touch with if you have got any concerns. So under 18 weeks of pregnancy, we recommend women go to A&E or their GP, depending on how severe their symptoms are. A&E and GP normally do refer the women to the early pregnancy unit, which is called Jasmine here at Kingston Hospital. You can actually talk to Jasmine yourself. They do prefer referrals, but if you are worried, you can give them a call and have a chat with about what you're worried about. Once they get over 18 weeks, then we've got a day assessment unit. The phone number is up on the screen there, but like I said, it is on the front of their notes as well. The day assessment unit are open, well, she's written Monday to Friday, but they are actually open on a Saturday as well, but only till 2 o'clock. So 9 to 5 Monday to Friday and 9 till 2 on a Saturday. They are closed on Sundays. If day assessment unit are closed, then you've got our triage. So they are open 24 hours a day, 7 days a week, and someone will always answer that phone. And obviously, if it's a major emergency, we would encourage you to dial 999 or for the woman to partner or whoever to dial 999. Okay, so this slide just tells you a bit about some obstetric emergencies which you might come across out in community. If you are out of the hospital, then it's normal 999 number. If you're in the hospital, we have an emergency number, which is 2222, so 4 twos. That will get you through to the switchboard. You just tell them where you are and what your emergency is, and the relevant people will come. Lucy's put some little videos on here. I don't know if she was planning to actually show them to you. I'm not sure how long they are, so I think I'll skip over them for now because they might be quite we'll send them all over to you, but they might just be quite time consuming, so I'm aware of the clock. So there's information on maternal cardiac arrest. So, I mean, this is really unusual, but if anyone collapsed in your clinic, then I'm sure you probably all do basic life support training anyway, I'm sure. But it gives you a bit of, that will give you a little step-by-step guide to some maternal cardiac arrest. The slight difference is when women are pregnant, because obviously they've got a large bump in front of them, and that can be quite problematical doing cardiac arrest, cardiac compressions. That's a whole other training session, so I'm not going to go into that now. There's also a link here to neonatal resuscitation. So if you had a baby who collapsed with you, there's a little guide there to what you need to do. Postpartum hemorrhage. So this can happen immediately after delivery, or they can have something called a secondary PPH, which can happen a week, 2 weeks, 3 weeks after delivery, and that's just basically they start hemorrhaging. Postpartum women and pregnant women can actually bleed really profusely because they've got massive blood vessels in their uterus, and it is an obstetric emergency. So, like I said, either 999 or 2222 if you're in the hospital. Oh, and Lucy did also add on a little video about normal birth, because you never know, someone might turn up to your clinic having contractions. Women who've had babies before can actually deliver really quickly. So it's well worth just knowing what to do. Okay, right, so that is the end of the slideshow that Lucy has prepared. I don't know if there's any more questions in the chat. Let me just get it back up. No. Yep.
Oh, I had one question about your birth reflection clinics.
Yep.
What is it that you actually offer during those appointments? Is it just a one session appointment, or do you meet women a number of times? Like, well, what do they actually consist of?
So it's normally a one appointment clinic, but if there's a lot to discuss, then Sarah might arrange for them to come back again. So what she normally does is she gets their notes from their delivery, so she can run through them step by step with the women. I think the appointment's normally an hour long, so it's generally enough to kind of go through what happened. But if they are particularly upset or they had quite a long, I know some people are concerned, have worries about what happened antenatally and in labour and postnatally, so it can be quite time consuming. So that normally gets assessed by Sarah, and if she needs to bring them back, she will bring them back. To be honest, I don't actually know what happens if she hasn't kind of got through it all within a couple of sessions. I'm sure she would be seeing them again, or she would refer them in for a consultant review. But that's something we can chase up and find out about. I've never been in her clinic.
Yeah, I think it's quite a wide range of practices across different hospitals with regards to those clinics. So that's, yeah, it's helpful.
Yeah. I mean, they definitely, Miss Wilcock, our consultant mental health lead, likes to, from a postnatal point of view, likes there to be quite a large gap before she does those appointments, just so people have had time to sort of really think about what happened and break it down. If she feels that if you do it too soon, then they haven't had time to kind of really think about it properly first. We can also offer the clinics for women who are antenatal. So if when they get pregnant again, they start thinking about their first delivery and think, oh my gosh, that was actually quite traumatic, or I'm not sure why that happened, then they can come during pregnancy and do reflections on what happened in their previous pregnancy or the one before, whatever they want to reflect on.
Thank you, that's helpful. So I think Lydia's got a question in the chat as well.
Yeah, I can just see that actually. So you're just asking about if they've given birth elsewhere.
Yeah.
Yeah, so ideally, you'd like to think she had some sort of reflection done at the hospital where there was a problem. But we can do reflections on births that happen in other hospitals, but we have to request the notes from that hospital. So sometimes that can take quite a long time, or they can be a bit slow at getting the notes over to us. Mm-hmm. And obviously we can't, it's difficult to sort of say if that is normal practice or not in another hospital, but we can definitely do some sort of reflection with them, even if they gave birth elsewhere.
Okay. I had another question as well, if that's okay, about the obstetric cholestasis. I have a patient who, she's 36 weeks now, and she was recently diagnosed with that. So I think she's having sort of weekly or twice weekly blood tests, and she'll be induced at some point. I was just wondering kind of if you could tell us a bit more about how it's managed kind of once it's diagnosed, and if there's anything apart from the itching to sort of know if you know they already have it.
No, so it's quite a rare condition. It tends to happen later on in pregnancy, and most women, the main sign is that they feel itchy. That itching is normally much worse on the palms of their hands and the soles of their feet. So really quite unusual places for people to be itchy. Lots of women will complain about itching over their tummies, which is really normal because that's skin stretching. So that's not really anything to be worried about if there's no itching on the hands and feet. No, so blood tests are what diagnose the obstetric cholestasis, and even if they get diagnosed with it, it doesn't automatically mean their baby's going to be born straight away. It's often just managed. It's not really anything we can do, but they will get seen once or twice a week and have lots of blood tests. What happens is the results are monitored, and if those results start changing quite quickly, or if they start getting towards the levels where the doctors aren't happy, then they will generally induce the women. So it's not a sort of a major emergency where the baby needs to be delivered now. They've got a bit of time on their hands, so it's normally an induction that the women will get, unless the results really go off the scale, and then they might say, right, we need to get this baby out now. Obstetric cholestasis really increases the risk of stillbirth, so it's quite a serious illness. Did you ask me anything else though about obstetric cholestasis? Sorry, have I answered your question?
No, yeah, we've answered it. Thank you.
Fab.
I think Roshi's got a hand up. I don't know if she had a question.
Yeah, I was just wondering about hyperemesis, really. We've had quite a few women of late with hyperemesis, and we're just wondering about the management. I know on a couple of occasions some of the women have gone back for hydration and antiemetics and been admitted for a few days. And so I was just wondering if you've got any sort of anything you could share with us in terms of helping, because obviously they get psychologically, to get very down as well, very depressed.
It's really difficult. So because normally hyperemesis happens really early on in pregnancy, we don't really tend to see that in the maternity unit. So they go to our Isabella ward, which is our gynae ward, and then they go in there and they get rehydrated and they get medicated. And I know they have, I think they do like a little day unit thing for people with hyperemesis, so they can come in and they get a drip and they get their fluids and then they can go home again. Unfortunately, there's not really much we can do for hyperemesis other than fluids and antiemetics. So if women are saying to you they're feeling really nauseous, really sick early on in pregnancy, they can see the GP, and the GP can prescribe antiemetics for them. And then if they are really struggling to keep fluids down or the antiemetics aren't working, then they might have to look at coming in for some sort of treatment. But unfortunately, nausea and vomiting is one of the side effects of being pregnant.
Yeah, and is there any reason why is it all to do with just the body's makeup really? How some women are more prone to it than others?
Yeah, it's hormones. So you tend to find that women who are carrying twins have a lot more nausea than women that are just carrying one baby. But equally, it's so different for everyone. Some women are really, really nauseous. Some women don't seem to have any nausea at all. And it doesn't indicate how the pregnancy is going to go. It's just you. It's the same. All the pregnancy symptoms vary so much from person to person. So, you know, some people will get the constipation, other people won't. Some people get the varicose veins. It's all very hit and miss. You never really know who's going to get hit with what.
Yeah. Okay, thank you.
Anyone else?
Can I ask about elective cesarean sections?
Yeah.
Lucy mentioned that you'd had the rate had gone up in Kingston. And I've noticed quite a number of women of my patients in Wandsworth are requesting elective sections just by choice. At Kingston, is maternal choice taken into account? And do you think that that might be contributing to the higher rates?
Definitely maternal choice is taken into account. We have a clinic here at Kingston called Birth Options. So if anyone requests a caesarean section just for maternal request, then they will get seen in that clinic. That they then get given all the information about having a caesarean section versus vaginal delivery. They get given some bits of paper that have loads of statistics on them. So lots of statistics about their risk of bleeding, their risk of having a baby that needs neonatal admission, lots and lots of information. They're normally then sent away with that information to think about it and to read through it and to do some of their own investigations. And then they are brought back at a later date. And then they're asked, what's your opinion now? Have you changed your opinion? There's definitely a push to not do elective caesarean sections on people that don't have any medical reason for it. But if people at the end of the day are saying that's really what I want, then we can't say no.
Thanks. That's helpful.
Any other questions from anyone?
So I was just going to ask about so when women have reached their due date, and is it that are they seen every once a week then thereafter their due date in terms of their management?
So they get seen at 41 weeks.
Mm-hmm.
And then at 41 weeks, they are offered a sweep, if they want, a stretch and sweep of the cervix, which is kind of a natural way to try and push their bodies to go into labour. That is optional. They don't have to do that at all. But then at 41 plus 5, we are then looking to induce them. Ideally, we want them to have their babies by 42 weeks. This is along with the national guidelines. Again, we can't make women be induced. So if they say no, then we formulate a plan with them. So we'll bring them into our clinic. They get a scan to check how the placenta's functioning. They'll have a chat with the doctor, and they'll give them the risks involved with going over their due date. And then if they still choose to wait, they absolutely can. But they do need to come in every couple of days just to have a full antenatal check and make sure that they're all okay.
Okay, thank you. And just one more question on that one. So I know there has been various means of inducing women, so such as the pessaries and the hormone drips, etc. But I've heard of a new one now, the balloon. I don't know whether you could just tell me a little bit about that.
Yeah, so the little balloon. They started doing this because they don't like to use the hormones on women who've had a caesarean section in the past because of the risk of the scar rupturing during labour. Because the hormones can make the contractions come on really thick and fast. So the little balloon was designed to induce women without giving them hormones. So basically, it's like a little catheter which goes through the cervix, the little balloon on the end, and they add fluid to it, so it fills up and it dilates the cervix that way. I don't think we're doing that. We were doing it for a little while, but there's a new way now that I don't know if you've heard of. It's called Dilapan.
No.
And they're actually but this is quite a new thing that's only happened fairly recently. And then this is a way also, it's pretty similar. This is a way of inducing women, without using the hormones. So they're like little rods 3 little rods that go through the neck of the womb, and they sort of swell up. So they do a very similar thing to the balloon. So they're kind of pushing the cervix open rather than the hormone that's doing the softening.
Okay.
So yeah.
Is there a first preference then? Do women have to sort of have a first step, second step, third step?
Yeah, so at the moment we offer inpatient and outpatient induction. So if everything's been normal and straightforward, then women can go home during the induction process. So we normally bring them in, get them seen, get them checked over. If everything's fine, once we've given them the pessary, which is called prostin, then they can go home with that.
Okay.
They then come back after 24 hours. And obviously we give them a whole checklist of things. So, you know, if they start bleeding or if they're contracting, then they must call and they must come back. But if they go home and everything's fine, then they don't need to come back for 24 hours. The women that are having the dilapan, they actually have to stay in. So we're only doing that on inpatient inductions at the moment. The induction, what we choose to do for women normally depends on if they're able just to go home or not. So that's kind of how we decide what induction process we're going to use. There's a kind of a 3-step process to being induced, and we just don't really know where people are going to step on and step off that process, because induction works very differently for everybody. So kind of in a textbook manner, it starts off with either the pessary or the dilapan. After 24 hours, then we move on to breaking the waters. And then we normally give women a few hours after waters have broken to go for a bit of a walk and mobilise, and that often gets the contractions going. And then after that, then we start the hormone drip. So, I mean, like I said, sometimes the women get the pessary, and then within a couple of hours they're contracting and off they go and they have a baby within a few hours. Other women get all the way to the end, they get the hormone drip going, and even then they don't go into labour and they end up with a caesarean section. So it's very unpredictable.
Okay, thank you. Thank you for that.
That's okay.
Can I just jump in, sorry, and ask just on induction as well? I have quite a few ladies recently with sort of history of sexual trauma and real aversion to having internal examinations and things, and some of them are being induced. Do they ever get the option? Can they just like go straight for the drip so that they don't have to have sort of lots of ins and outs, or is that a no? Is it dangerous? Or
it's not dangerous, but the problem is if the cervix isn't ready for labour, putting the drip on them is just going to give them lots and lots and lots of contractions and not actually be doing anything, because they're just not in the right stage to have contractions, if you understand what I mean. Yeah. I think if people are really struggling with thought of vaginal examinations, then they might have to consider going straight for a caesarean section if they get to that point, because there are unfortunately quite a few examinations involved in being induced.
Okay, thank you.
Okay, anyone else? No,
that was wonderful. Thank you.
Thank you, Jo.
Okay. Okay, so we'll make sure
Lucie back yet.
She's in the room, but she's on the phone.
Okay.
Do you want to talk to her, Maria?
No. I just wondered if there was anything else she wanted to add, or she had any issues she wanted to bring back. But if she's busy, nothing else. No, thank you.
There's a little drama going on. What we'll do is I'll speak to Lucie, see if there's anything else, and then we'll make sure you get all these slides so you can see everything. Is that okay?
Yeah, lovely. Thank you very much.
Thank you. Thank you so much.
Thank you. Thanks. Bye.
Bye.
Thank you.
We have a few minutes left, 10, until we were due to have the Japanese childbearing experiences. Should we have a break, or?
I think we start at 3. Don't we start at 3?
Oh yes, you're right. Yeah.
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 So
But,
see
but
you.
Maria, I know you're back. I know you're back in Kingston a lot, but that was wonderful. So thank you to all those, isn't it, over at Kingston? That was wonderful.
Yeah, it was really, really good.
Yeah.
Yeah. So are we going to wait for that long break now? Or would people be happy to bring it forward a little bit and finish earlier?
Yeah, I can't remember who's first. Jill, you're first.
Jill doing Japan.
If Jill's ready, we need to change the link anyway, so we need to come out of this meeting. But
okay. Should we just have a quick look at the program and organize the rest of the afternoon to see if we can finish earlier?
I think we've lost Jill, haven't we? She's not here.
Yeah, I think she signed off.
She's had enough.
Okay. So in the timetable, the next session is 3 o'clock, Japanese experience, which is Jill. Then the traveling communities, Shireen. Then at 4 o'clock, we had Jewish childbirth practices, Leela. And then Hinduism at the end, which is Ahmed. And each one has half an hour.
So shall we ask if we can start earlier? We'll start, what, 2:45?
If we grab a coffee or tea for about 10-15 minutes, and then we could start 2:45 at the latest, really.
Yeah, I mean, I'm going to be honest, from my point of view, I hope I shouldn't take half an hour, and there's no guest, so I can do it in any order you want.
Okay, so should we just say we'll reconvene at 2:45, and then we just go one after each other? We just have a coffee break now, and we just go straight till the end with the 4 presentations, yeah?
Yeah, we'll start the meeting at 2:45, so we'll see you all
that
there.
makes sense. And then hopefully we can finish a little bit earlier. Okay, thank you. See you then.
Great, thanks.
Do we need to reconnect, Aki?
Yeah, there's a different link for that one.
Okay, so that's fine. Thank you.
Thanks, guys.